This presentation is on attention deficit hyperactivity disorder in children and adolescents, diagnosis, treatment, and evaluation of outcomes by Leah Monte, Aaron Torres, and Caitlin Dupre.
Learning objectives. Upon completion, the participant will be able to identify current diagnostic criteria for ADHD, identify risk factors and comorbidities of ADHD, identify the differential diagnoses associated with ADHD, and discuss various treatment options for ADHD. Pretest. ADHD symptoms must have been present before the age of A, 2, B, 6, C, 12, or D, no specific age. Number 2, true or false? ADHD symptoms must be present in at least one setting, home or school. Pretest continued. Number 3, the following are risk factors for ADHD. A, brain trauma. B, environmental exposure. C, high diet and sugar. Or D, low birth weight. Number 4, true or false? Pharmacotherapy with or without behavior or psychological interventions is the first line therapy for children 6 and older and adolescents who meet diagnostic criteria for ADHD. Pretest continued. Number 5, ADHD stimulant medications are used to A, cure ADHD, B, improve motivation, C, improve self-control, or D, teach the child to behave.
ADHD is a psychiatric condition and neurodevelopmental disorder that is characterized by developmentally inappropriate levels of impulsivity, hyperactivity, and inattention. Children and adolescents with ADHD show disabilities in focus, decision-making, and emotional regulation. If unrecognized and untreated, it can lead to problems throughout the lifespan. To fully understand ADHD, it's important to know some of its background and history. Now, the history of ADHD goes back to the 19th century, where it was referred to as a hyperactive or hyperkinetic syndrome, and this fell under a very broad category of minimal brain dysfunction. Now, this minimal brain dysfunction was noted to be in contrast to those who had more explicit genetically based neurodevelopmental disorders, such as Down syndrome. Now, the group defined as brain damage was very broadly defined, and eventually over time it was continually narrowed down, and the view of brain damage as the cause was just kind of done away with. In 1980, a lot of our research by psychologists using continuous performance tests resulted eventually in the DSM-2 creating the hyperactive reaction of childhood diagnosis. And in the DSM-3, this eventually became attention deficit disorder. Finally, it's undergone several revisions, and with the publication of the Diagnostic and Statistical Manual 5th edition, the DSM-5, ADHD was officially recognized as a neurodevelopmental disorder. The etiology of ADHD is related to a variety of factors that include both an environmental and genetic component. It is one of the most heritable conditions in terms of psychiatric disorders. Siblings have twice the risk of having ADHD than the general population. There's no consistent findings on the brain imaging of individuals with ADHD. Some causative factors have been explored, such as viral infections, nutritional deficiency, smoking during pregnancy, and alcohol exposure to the fetus, and these have been explored as possible causes of the disorder. The number of dopaminergic receptors and noradrenergic receptors have also been implicated in the development of the disorder, where research has shown that the receptors are decreased in the frontal lobes of individuals with ADHD. But ultimately, it's one of the most prevalent disorders that is found in childhood.
Now we will discuss the diagnostic considerations for ADHD. The American Psychiatric Association differentiates ADHD into two separate categories: inattention and hyperactivity impulsivity. Patients can meet the diagnostic criteria for both inattention and hyperactivity and impulsivity, so should be assessed for both. At least 6 symptoms that will be discussed must be present from either inattention or hyperactivity. For a diagnosis to be present, these symptoms must be present for at least 6 months, must be negatively impacting social, academic, or professional activities, and are not consistent with developmental level. This is the diagnostic criteria for the inattentive specifier. Of note, when considering the symptom of finding organization difficult, this really means in every manner of life. Difficulty managing tasks, not losing materials and belongings daily, lives with a messy or disorganized workplace, and is so disorganized that they often miss deadlines. Also, it is important to note that the additional stimuli that causes complete distraction may include uncontrolled and unrelated thoughts. Now we will look at the diagnostic criteria for symptoms for the hyperactivity and impulsivity specifier. In references to running and climbing in situations where it is inappropriate, this is often seen in children. For adults or adolescents, this is often seen as difficulty remaining in place for even a small amount of time. Now we have the remainder of possible symptoms to assess for regarding the hyperactivity and impulsivity specifiers for ADHD. Of note, the criteria for interjecting onto others is seen as people butting into others' conversation or activities, even taking over the occupational duties of other people. Here are the specifiers with their diagnostic codes that are required when making an ADHD diagnosis. Patients can present with having a predominantly inattentive presentation, predominantly hyperactive impulsive presentation, or a combined presentation, meaning the patient meets diagnostic criteria for both inattentive and hyperactive impulsive types.
Above are some screening and diagnostic tools that can be used to assist you in making an accurate diagnosis. The validity of these screening tools is typically going to be dependent on the child's age and what rating scale is being used and what information the source, either the teacher or the parent, is providing you with. And in the case of adolescents, they can also be your source. One of the most widely used tools is the Connors rating scale, which has been found to have high reliability and validity in both rating ADHD symptoms and also in identifying comorbidities. And this is important because the American Academy of Child and Adolescent Psychiatry recommends mandatory screening for ADHD during mental health evaluations, and they really highlight the significance of these screenings and the clinical interviews to help you assess for comorbid psychiatric disorders.
Above are some conditions that are commonly misdiagnosed as ADHD or vice versa. It is important to note that a lot of these conditions also co-occur with ADHD. With that being said, it is vital for providers to be able to assess for the correct diagnostic criteria and utilize appropriate screening tools to differentiate these diagnoses in children so proper treatment can properly begin. These are some common co-occurring disorders that often accompany an ADHD diagnosis with children. Of interest, 42% of children diagnosed with autism spectrum disorder also meet the criteria for an ADHD diagnosis. Among these disorders listed Oppositional defiant disorder, depression, and anxiety disorders are the top 3 comorbid disorders occurring in ADHD. Interestingly, it is found that ADHD and ODD co-occur in about half of children with combined presentation specifier of ADHD.
Untreated ADHD. Functional consequences for the child and adolescent. Children with ADHD can struggle in class, leading to academic failure and criticism by other children and adults. They can also have problems engaging or being accepted by peers and adults. They tend to have more accidents and injuries than others, low self-esteem, and increased risk of alcohol, drug abuse, and delinquent behavior.
The FDA has approved both methylphenidate and amphetamines for the treatment of ADHD in children and adolescents. Amphetamines such as Adderall are approved in children as young as 3. MPHs are approved in children 6 and older. Here is a list of monitoring considerations providers should consider before initiating treatment of stimulants. Before the initiation of treatment, it can be important to assess for a presence of cardiac abnormalities. Having a detailed personal and family history, as well as a physical exam, should be warranted before initiating stimulants. Current guidelines do recommend considering an EKG in some circumstances and consider referring children to cardiology specialists with findings suggestive of cardiac disease. Now we're going to take a look at how stimulants affect the chemistry within our brain. These drugs are psychostimulants, meaning they increase the central nervous system activity in the brain, and as a result can possibly increase both pulse rate and blood pressure. Stimulants work by primarily increasing dopamine and norepinephrine concentration levels in the synaptic cleft, although different medications may have slightly different mechanisms of action. Listed here are common short and long-term effects possibly seen when starting stimulants on children and adolescents. Withdrawal effects or rebound effects are possible with stimulant use as well. This presents as a sudden return of more severe overreactivity, impulsivity, and inattention in the late afternoon or evening than present at baseline off medication. In most children and adolescents, these effects are seen as transient or clinically insignificant, but changing the time and or dose of the medication will often resolve most of these short-term side effects. Growth suppression has been minimal and predominantly only within the first year of stimulant use. The effects on growth are thought to be secondary to appetite suppression. Currently, there is no evidence to suggest that the use of stimulants in children or adolescents increases the risk of developing a substance use disorder in childhood or later in adulthood. Even with this lack of evidence, it is important for providers to remember that these medications can be misused for academic enhancement or for the euphoric effect. Now we're going to touch on the non-stimulant options to treat ADHD. Although not the first-line treatment, some children, especially those with co-occurring disorders, may benefit from a non-stimulant option of medication. ATX can be considered first-line in individuals where parents have a personal objection to stimulants, the child has comorbid anxiety symptoms, or has experienced severe stimulant side effects. Alpha-adrenergic agonists, guanfacine and clonidine, have been FDA approved as monotherapy and as adjunctive treatment for ADHD in children 6 to 17 years old. These medications have shown particular success when treating children with co-occurring conditions. Clonidine has been shown to successfully treat those with ADHD and Tourette syndrome either as monotherapy or an adjunct with an MPH, while guanfacine has shown to improve oppositional symptoms in children with ODD. Common side effects of these alpha-adrenergic medications are sedation, fatigue, hypotension, headache, and bradycardia. Quinidine in particular is very sedating and has actually been used to treat sleep disturbances in children with ADHD. It is important to note the psychotherapeutic options available for children and adolescents with ADHD. For children under 5 years of age, parent training programs and parent group training programs are actually considered first-line treatments. Studies have found that combination of pharmacological and non-pharmacological treatments have yielded the best results for pediatric patients. Cognitive behavior therapy creates opportunities for children to recognize the differences between their negative and desired actions. CBT can focus on more specific forms of behavioral training, focusing on social skills training, training of planning and organizational skills, and self-management techniques. This has positive effects on behavior, parenting skills, child-parent relationships, and certain daily living skills. Family therapy can be crucial to evaluate the parents and family for dysfunction related to the child's ADHD, so parents can learn proper techniques of not only discipline, but how to reward positive behaviors as well. Contingency management uses a punishment reward system, often in special settings like the classroom or home specifically. It is not the most effective because when the child is not in those settings, the negative behaviors commonly reappear when rewards are not available.
Evaluation of treatment outcomes. Effective response to treatment can be reduction of core symptoms. This can be 40 to 50% reduction compared to baseline. This can be monitored by ADHD specific rating scales. Another effective response is improvement in target goals. This can be a reduction in missing assignments from 60% to 20% per week. This can be monitored through a daily, weekly report card or written report cards from the child's teacher. Although caregiver reports are helpful, they aren't a good substitute for teacher reports. Ineffective response to treatment include comorbidities. This includes language or learning disabilities, mental health disorders, psychosocial stressor. Treatment plan non-adherence. They may be forgetting to take the medication. And lastly, misdiagnosis.
We based our presentation on the theory of constructivism. This is ideal throughout medicine because we as providers have to be learning with every patient and circumstance presented to us. Whether in clinical or with the utilization of case studies, learning should be evolving and growing all the time. The main principles of constructivism include that knowledge is created or constructed versus being passively absorbed through another's teachings. Learning is an active process, and all knowledge is socially constructed and is personal.
Post-test. Number 1. ADHD symptoms must have been present before the age of C. 12. According to the DSM-5, several of the symptoms must have been present before the age of 12. Number 2. True or false? ADHD symptoms must be present in at least one setting, home or school. False. Symptoms must be present in at least 2 different settings. Post-test continued. Number 3. The following are risk factors for ADHD, except C. High diet and sugar. There is no evidence that supports the view that ADHD can be caused by eating too much sugar, watching too much television, parenting, or social environmental factors at this time. Number 4. True or false? Pharmacotherapy with or without behavior psychological interventions is a first-line therapy for children 6 and older and adolescents who meet diagnostic criteria for ADHD. This is true. Medication, with or without behavioral or psychotherapy, is recommended as first-line therapy for children 6 and older and adolescents who meet diagnostic criteria. Question number 5. ADHD stimulant medications are used to C. Improve self-control. Medications will not cure ADHD, teach the child to behave, follow the rules, or to be motivated.